This is Chapter 19, Timby, and 47 from Concepts. The concept is safety. Learning objectives. Discuss the purpose of the National Patient Safety Goals, NPSGs, and methods for implementing them. Give an example of one common injury that predominates during each developmental stage, infancy through older adulthood. Name 6 injuries that result from environmental hazards. Identify at least 2 methods for reducing latex sensitization. List 4 areas of responsibility incorporated into most fire plans. Describe the indications for using each class of fire extinguishers. Discuss 5 measures for preventing burns. Name 3 common causes of asphyxiation. Discuss 2 methods for preventing drowning. Explain why humans are susceptible to electrical shock. Discuss 3 methods for preventing electrical shock. Name at least 6 common substances associated with poisonings. Discuss 4 methods for preventing poisonings. Discuss the benefits and risks of using physical restraints. Explain the basis for enacting restraint legislation and the Joint Commission's accreditation standards. Differentiate between a restraint and a restraint alternative. Give at least 4 criteria for applying a physical restraint. Describe 2 areas of concern during an accident. Explain why older adults are prone to falling. There was and is an urgent focus on safety, measures that prevent accidents or unintentional injuries, following a shocking article written by Dr. Starfield in 2000, published in the Journal of the American Medical Association. In her article, Dr. Starfield reported that most hospital deaths and injuries are attributed to medication errors and adverse medication effects, infections, and surgical errors. It identified and ranked by the National Center for Health Statistics deaths from hospital errors, excluding preventable deaths due to medical treatments outside of hospitals, and it would be the 3rd leading cause of death. Such findings validate the conclusion that receiving health care is an extreme risk to a person's safety. We will examine people at risk for injuries, environmental hazards in homes and healthcare facilities, and nursing measures that keep clients safe. Shortly after Dr. Starfield's article, the Joint Commission began considering safety a priority when caring for clients and began establishing National Patient Safety Goals, known as NPSGs, in 2003. Since that time, there have been subsequent updates, the most recent being in 2016. The purpose of these goals is to help healthcare organizations obtain and retain their accreditation by demonstrating safe and effective care of the highest quality by reducing the risk of adverse client outcomes. The goals are revised regularly based on the recommendations of the Patient Safety Advisory Group, which is made up of nurses, physicians, pharmacists, and others, to reduce the incidences of death and injuries among those being cared for in healthcare agencies. Methods of implementing the goals are integrated within the nursing skills that appear in this text. Age-related safety factors. No age group is immune to accidental injury. Distinct differences among age groups exist. However, because of varying levels of cognitive function and judgment, activity and mobility, and degree of supervision, as well as the design of and safety devices within physical surroundings. Infants and toddlers. Infants rely on the safety consciousness of their adult caretakers. They are especially vulnerable to injuries resulting from falling off changing tables or being unrestrained in automobiles. Toddlers are naturally inquisitive and more mobile than infants and fail to understand the dangers that accompany climbing. Consequently, they are often the victims of accidental poisoning, falls down the stairs or from high chairs, burns, electrocution from exploring outlets or manipulating electrical cords, and drowning. School-age children and adolescents. School-age children are physically active, which makes them prone to play-related injuries. Many adolescents suffer sports-related injuries because they participate in physically challenging activities, sometimes without adequate protective equipment, before their musculoskeletal system can withstand the stress. Adolescents also tend to be impulsive and take risks as a result of poor judgment and peer pressure. Adults are at risk for injuries from ignoring safety issues such as driving while texting or talking on a cell phone, failing to use seatbelts, fatigue, sensory changes, and effects of disease. The types of injuries that young, middle-aged, and older adults incur depend on their social, developmental, and physical differences. Environmental hazards. Environmental hazards are potentially dangerous conditions in the physical surroundings. Examples in the home and healthcare environment include latex sensitization, thermal burns, asphyxiation, electrical shock, poisoning, and falls. Latex sensitization. Increasing numbers of people are developing latex sensitivity, which is allergic response to the proteins in latex. Latex, a natural rubber sap whose origin is a species of tree indigenous to Brazil, is a component of many household items, such as balloons, envelope glue, erasers, and carpet backing, as well as healthcare products. Health-related sensitization is partly the result of repeated exposure to latex in medical gloves and other equipment. Clients predisposed to latex sensitivity include those with a history of asthma and allergies to other substances, multiple surgeries, and recurring medical procedures. Many of the safety concepts in the healthcare literature originate from the Institute of Medicine's groundbreaking work in patient safety. Beginning with the 2000 publication To Err is Human, the Institute of Medicine alerted the healthcare industry and the public to the problems of deaths from preventable errors. In this report, the Institute of Medicine offers a definition of safety as, quote, freedom from accidental injury, unquote. An expanded definition of patient safety is offered in this report's appendix. Quote, freedom from accidental injury, ensuring patient safety involves the establishment of operational systems and processes that minimize the likelihood of errors and maximizes the likelihood of intercepting them when they occur, unquote. So an important emphasis in this Institute of Medicine's report of 2011, Crossing the Quality Chasm, is the expectation of consistent safety in our healthcare systems. Their point, the healthcare environment should be safe for all patients in all of its processes all of the time. This standard of safety implies that organizations should not have different, lower standards of care on nights and weekends or during time of organizational change. In the third report, Keeping Patients Safe, 2004, the Institute of Medicine defines safe care as care that maintains a focus on using evidence in clinical decisions so to maximize the health outcomes while also reducing the potential for harm. The National Patient Safety Foundation, NPSF, is an independent, not-for-profit organization with a goal to improve the safety of healthcare for all patients. The NPSF defines patient safety as, quote, the prevention of healthcare errors and the elimination or mitigation of patient injury caused by healthcare errors. Also, they define healthcare errors as unintended healthcare outcomes caused by a defect in the delivery of care to a patient. Healthcare errors may be errors of commission, doing the wrong thing, omission, not doing the right thing, or execution, doing the right thing incorrectly. Errors may be made by any member of the healthcare team in any healthcare setting. A 2014 National Patient Safety Foundation report, Safety is Personal, Partnering with Patients and Families for the Safest Care, expands the concept of patient safety to reflect recent research. A key component is how providers work with the patient and family as a safety ally. They can be invited to observe and report gaps or omissions in care and help avoid errors and near misses. The work of defining safety and safe care by the IOM, Institute of Medicine, is relevant for all healthcare professionals and emphasizes safety from the patient's perspective. In nursing, a Robert Wood Johnson Foundation funded National Initiative Quality and Safety for Nurses, QSEN, builds on Institute of Medicine's work and defines safety as minimizing the risk of harm to patients and providers through both system effectiveness and individual performance. This competency definition is further explained by the necessary knowledge, skill, and attitude elements to demonstrate safety in one's practice and can be found on QSEN's website. Levels of errors are important definitions to understand. The Institute of Medicine offers definitions of an adverse event and a near miss, and the Joint Commission offers a definition of a sentinel event as follows. An adverse event is an event that results in unintended harm to the patient by an act of commission or omission, rather than by the underlying disease or condition of the patient. Adverse event. Again, an event that results in unintended harm to the patient by an act of commission or omission, rather than by the underlying disease or condition of the patient. Near miss is an error of commission, in other words, they did not provide care correctly, or omission, did not provide care that could have harmed the patient, but serious harm did not occur as a result of chance. The patient received a contraindicated drug, but did not experience an adverse drug reaction. Prevention, a potentially lethal overdose was prescribed, but a nurse identified the error before administering the medication. Or mitigation, a lethal dose was administered but discovered early and countered with an antidote. They're all near misses. Sentinel event is an unexpected occurrence involving death or serious physical or psychological injury or the risk of. Serious injury specifically includes loss of limb or function. The phrase or the risk thereof includes any process variation for which a recurrence would carry a significant chance of a serious adverse outcome. Such events are called sentinel because they signal the need for immediate investigation and response. Scope. The concept of safety is broad and encompasses the ideal of keeping all patients safe to the unfortunate reality that errors can lead to injury or death. Several key elements associated with this perspective include gaining an understanding of the types of errors, placement of errors, and ways of building a culture of safety. In your book, Concepts, page 446, there's a figure 47.2 called active and latent errors. On the blunt end of the triangle are latent errors in organizational/system. On the sharp end are active errors in direct patient care. Types of errors. In nursing, safety has focused on the safe execution of specific procedures and tasks. Recent safety work has emphasized the variety of errors that compromise patient safety and the range of variables that impact the occurrence of errors in healthcare. Understanding types of errors in healthcare is a vital element in addressing individual practice and improving healthcare systems. In its early report, Institute of Medicine cites a pioneer in the field of patient safety, Lucian Leape, L-E-A-P-E, who identified 4 types of errors. Diagnostic errors are the result of a delay in diagnosis, a failure to employ indicated tests, use of outmoded tests, or failure to act on results of monitoring or testing. 2. Treatment errors occur in the performance of an operation, procedure, or test in administering a treatment, in the dose or method of administering a drug, or in avoidable delay in treatment, or in responding to an abnormal test. 3. Preventive errors occur when there are failures to provide prophylactic treatment and inadequate monitoring or follow-up of treatment. 4. Communication failure, meaning a lack of communication or a lack of clarity in communication, can lead to many types of errors. By employing a standardized system for classifying different types of errors, best practices can be developed to address safety compromises in healthcare systems. Placement of errors. Along with types of error, the placement of errors may be described as active or latent. This distinction is important in further understanding the cause of healthcare errors and appropriate improvements. In healthcare, active errors are made by those providers such as nurses, physicians, and technicians who are providing patient care, responding to patient needs at the sharp end, which is at the point of care. Latent conditions, and the sharp end means the triangle in the picture on page 446. Latent conditions are the potential contributing factors that are hidden and lie inactive in the healthcare delivery system, originating at more remote aspects of the healthcare system, far removed from the active end. Latent errors, more organizational, contextual, and diffuse in nature or design-related, are called errors occurring at the blunt end. A latent error is a flaw in a system that does not immediately lead to an accident, but establishes a situation in which a triggering event may lead to an error. Identifying errors as either latent or active in origin allows the exact system that needs improvement to be more accurately identified and corrected. Most bedside nurse clinicians operate at the sharp end of healthcare and are involved with active errors or inherent latent errors that can be manifested as active errors. For example, a nurse who administers the incorrect medication because of a failure to check the medication order is involved in an active error. However, a medication error can occur where a latent error can lead to an active error. For example, a latent error can lead to an active error if a Pyxis, or other medication administration system, is incorrectly stocked with a look-alike, sound-alike medication that a nurse mistakenly administers based on what should have been stocked in a certain Pyxis compartment. As nurses learn about differences between active and latent errors, they can more accurately identify and contribute to processes or systems for improvement. Age-related safety factors. No age group is immune to accidental injury. Distinct differences among age groups exist because of varying levels of cognitive function and judgment, activity and mobility, and degree of supervision, as well as the design and safety devices within physical surroundings. Infants and toddlers. Infants rely on the safety consciousness of their adult caretakers. They're especially vulnerable to injuries resulting from falling off changing tables or being unrestrained in automobiles. Toddlers are naturally inquisitive and more mobile than infants and fail to understand the dangers that accompany climbing. Consequently, they are often the victims of accidental poisoning, falls down the stairs or from high chairs, burns, electrocution from exploring outlets or manipulating electrical cords, and drowning. School-age children and adolescents. School-age children are physically active, which makes them prone to play-related injuries. Many adolescents suffer sports-related injuries because they participate in physically challenging activities, sometimes without adequate protective equipment, before their musculoskeletal systems can withstand the stress. Adolescents also tend to be impulsive and take risks as a result of poor judgment and peer pressure. Adults are at risk for injuries from ignoring safety issues, such as driving while texting or talking on a cell phone, failing to use seatbelts, fatigue, sensory changes, and effects of disease. The types of injuries that young, middle-aged, and older adults incur depend on their social, developmental, and physical differences. Environmental hazards. Environmental hazards are potentially dangerous conditions in the physical surroundings. Examples in the home and health care environment include latex sensitization, thermal burns, asphyxiation, electrical shock, poisoning, and falls. Latex sensitization. Increasing numbers of people are developing latex sensitivity, which is an allergic response to the proteins in latex. Latex is a natural rubber sap whose origin is a species of tree indigenous to Brazil, a component of many household items such as balloons, envelope glue, erasers, and carpet backing, as well as healthcare products. Health-related sensitization is partly the result of repeated exposure to latex in medical gloves and other equipment. Clients predisposed to latex sensitivity include those with a history of asthma and allergies to other substances, multiple surgeries, and recurring medical procedures. Types of reactions to latex. Sensitization follows latex exposure through the skin, mucous membranes, inhalation, ingestion, injection, or wound management. The two forms of allergic reactions to latex or the chemicals used in its manufacture are as follows. Contact dermatitis, a delayed, localized skin reaction that occurs within 6 to 48 hours and lasts for several days. acute hypersensitivity, an instantaneous or fairly prompt systemic reaction manifested by a variety of signs and symptoms such as swelling, itching, respiratory distress, hypotension, and death in severe cases. Sensitized people can develop a cross-reaction to fruits and vegetables such as avocados, bananas, almonds, peaches, kiwi, tomatoes, and others because the molecular structure of latex and other plant substances is similar. Safeguarding clients and healthcare providers. One of the best techniques for preventing latex sensitization and allergic reactions is to minimize or eliminate latex exposure. Healthcare agencies now provide healthcare providers with more than one type of glove. If they use latex gloves, nurses should use powder-free gloves, avoid snapping the gloves when donning or removing to avoid air dispersal of powder and latex proteins, reduce the time the gloves are worn, wash hands thoroughly with a pH-balanced soap such as Dove, Aquaderm, or Cetaphil, for example, after removing the gloves, and avoid using oil-based hand creams or lotions. Other measures to protect clients and healthcare providers include the following. Obtain an allergy history and ask about sensitivity to latex in particular. Flag the chart in room door and attach an allergy alert identification bracelet on latex-sensitive clients. Assign clients with a latex allergy to a private room or latex-safe environment. The room should be stocked with latex-free equipment and wiped clean of glove powder. Stock a room with latex-free equipment, including synthetic gloves and resuscitation equipment in the room of a client sensitive to latex. Wipe the room clean of glove powder. Communicate with personnel in other departments so that they use non-latex equipment and supplies during diagnostic or treatment procedures. Report allergic events and their possible causes promptly to the agency's administration. Administrators are required to report injuries, serious illnesses, or deaths from unsafe equipment to the U.S. Food and Drug Administration. Refer sensitized clients to latex allergy support groups. Recommend that latex-sensitive clients wear a medical alert bracelet at all times. Advise latex-sensitive clients to notify their employer's health officer about the allergy in case of a future claim for workman's comp or a legal case concerning discrimination in the workplace. Thermal burns. Thermal burns is a skin injury caused by flames, hot liquids, or steam and is the most common form of a burn. There are an average over 6,000 fires per year in healthcare facilities based on statistics gathered by the National Fire Protection Association as of 2013. The number of those fires varies according to the type of health facility. The causes of healthcare facility fires vary, with 61% attributed to unattended cooking or equipment, as well as ignition of cooking materials such as grease and oil. Burn prevention. Because many adults become complacent about safety hazards, the nurse should review burn prevention measures with clients being treated for thermal-related accidents. Exits must be identified, lit, and unlocked. Most fire codes require that public buildings, including hospitals and nursing homes, have a functioning sprinkler system. Sprinkler systems help control fires and limit structural damage. Fire plans. To prevent or limit burn injuries in a healthcare setting, all employees must know and follow the agency's fire plan, which is a procedure followed for a possible or actual fire. Compliance with the fire plan is a major component of the Joint Commission's inspection. Every accredited healthcare agency must demonstrate and document that all new and current staff members have been trained in the following 5 areas. Specific roles and responsibilities at and away from the fire's point of origin, use of the fire alarm system, roles in preparing for a building evacuation, location and proper use of equipment for evacuation or transporting clients to areas of refuge, building compartmentalization procedures for containing smoke and fire. To obtain the Joint Commission's accreditation, staff members on each shift must also participate in fire drills, the frequency of which must be identified in the agency's fire plan. Included in the plan are exits should be identified, lit, and unlocked, sprinkler systems in place and working, fire plans with practice, smoke and heat being sensitive. The CO directors, the detectors should be sensitive to smoke and heat. There should be proper storage of flammable materials. There should be smoking safety rules and places for smoking. There should be safety matches and flammable resistant clothing to stop, drop, and roll. And do not overload electrical outlets. Keep water thermostats less than 120 degrees centigrade and keep cords away from children. Flush chemicals with any kind of burn or exposure to burns with water. If there's a burning building, seal the door. If hot, close the door behind. Crawl. If there is a fire, crawl on the floor so that you can breathe, and use stairs, never elevators. Fire management. The National Fire Protection Association, whose life safety code is the basis for the Joint Commission's management standards, recommends using the acronym RACE to identify the basic steps to take when managing a fire. RACE: R, rescue; A, alarm; C, confine the fire; and E, extinguish. Most healthcare agencies incorporate these concepts by including the following sequence of actions in their fire plans. Evacuate the clients from the room with the fire. Inform the switchboard operator of the fire's location. He or she will alert personnel over the public address system and notify the fire department. Return to the nursing unit when an alarm sounds. Do not use the elevator. Clear the halls of visitors and equipment. Close the doors to client rooms and stairwells as well as fire doors between adjacent units. Wait for further directions. Place moist towels or bath blankets at the threshold of doors if smoke is escaping. Use an appropriate fire extinguisher if necessary. You want to pull the pin, aim the nozzle, squeeze the lever, and sweep side to side. Rescue and evacuation. The first priority is to rescue clients in the immediate vicinity of the fire. Nurses lead those who can walk to a safe area and close the room and fire doors after exiting. Using a variety of techniques, nursing personnel evacuate those who cannot walk. Fire extinguishers. There are various types of fire extinguishers. Each type is labeled. Nurses must know the type of extinguisher that is appropriate for a burning substance and how to use it. Again, pull the pin with the extinguisher in a downward position and release the locking mechanism. Aim the nozzle of the extinguisher at the base of the fire. Squeeze the lever slowly and evenly and sweep the nozzle from side to side. Class A fire is used for burning paper, wood, and cloth, and this consists of water under pressure. Class B fire is actually carbon dioxide. Used on fires caused by gasoline, oil, paint, grease, and other flammable liquids. Class C is made of dry chemicals, and this is for electrical fires. Class ABC is a combination extinguisher, and the contents are graphite, and its use can be done on fires of any kind. Asphyxiation is the inability to breathe. Can result from airway obstruction, drowning, or inhalation of noxious gases such as smoke or carbon monoxide. Smoke inhalation. Smoke can be more deadly than fire. It consists of incinerated particles, chemicals, and gases. The effects range from asphyxiation to chemical irritation and thermal damage. Almost all healthcare facilities have banned cigarette smoking. Consequently, smoke inhalation in those locations now accounts for far fewer deaths. However, when a fire occurs, regardless of its location or cause, smoke inhalation rather than burns results in 50 to 80% of the deaths. Symptoms from smoke inhalation range from coughing to impaired judgment, unconsciousness, and respiratory arrest. If superheated gases are inhaled, they can burn the respiratory tract and form carboxyhemoglobin, which is a compound of carbon dioxide with hemoglobin in the bloodstream, thereby depriving oxygen to the brain and other vital organs. Despite efforts to ban smoking, there continues to be a risk for fires from smoking in healthcare facilities and other non-residential locations. Some attribute this to the fact that secretive smokers tend to discard smoldering cigarette butts quickly to avoid being discovered. Home fires, on the other hand, often occur when smokers fall asleep with a burning cigarette or when children play with matches or lighters. Many homes and apartment buildings are equipped with smoke detectors. However, some people dismantle their smoke detector when it begins to emit an audible alarm signaling a low battery power. And because of the sound, they fail to replace the batteries twice a year when going from and into daylight savings time. Symptoms associated with carbon monoxide poisoning: dizziness, headache, disorientation, confusion, coma, visual disturbances, cherry skin color, aggravation of pre-existing heart and respiratory diseases, muscle weakness, muscle cramps, seizures, nausea and vomiting. Carbon monoxide poisoning is extremely lethal because it is colorless, odorless, and tasteless, earning it the reputation of leading to an invisible death. Carbon monoxide is released during the incomplete combustion of carbon products such as fossil fuels. Some examples in which carbon monoxide poisoning can occur include when unvented kerosene or space heaters are used, when a chimney is blocked or partially obstructed, when a motor vehicle attached to a garage is allowed to stand idling, and when using a hibachi or charcoal grill indoors. When inhaled, carbon monoxide binds with hemoglobin in preference to oxygen. Therefore, there is little oxygen available to cells and tissues. In addition, carbon monoxide binds to myoglobin, the protein that carries and stores oxygen in muscle cells, like the heart. With a reduced availability of oxygen to the heart, cardiac output is decreased and blood pressure falls, depriving the brain of oxygen. When cells suffer from hypoxia, aerobic metabolism is replaced by anaerobic metabolism, leading to metabolic acidosis and death. If survival occurs, cognitive defects such as impairment in memory and learning may persist. The average level of carbon monoxide in homes is 5 to 15 parts per million. Prolonged exposure to levels above 70 parts per million produce flu-like symptoms such as headache, nausea, vomiting, weakness, and confusion. When carbon monoxide gases accumulate above 150 to 200 parts per million, disorientation, unconsciousness, and death are possible. One of the classic signs of carbon monoxide poisoning is a bright cherry skin color that may persist even after death occurs. Prevention and treatment. Because carbon monoxide can be present even without smoke, the nurse recommends that carbon monoxide detectors should be installed in all homes, and the fire department should be summoned to investigate alarms. Without detectors, victims may be unaware that their symptoms are due to the accumulation of carbon monoxide. If a person is suspected of being poisoned by carbon monoxide, initial treatment requires getting the victim out of the present environment. If moving the person out of doors is impossible, rescuers should open windows and doors to reduce the level of toxic gas and promote adequate ventilation. Once emergency personnel arrive, they administer oxygen. In the case of extremely high blood levels of carbon monoxide, the victim may be treated with hyperbaric, which is high-pressure oxygen. Drowning is a condition in which fluid occupies the airway and interferes with ventilation. It can occur in swimmers and non-swimmers alike. Accidental drownings occur during water activities such as fishing, boating, swimming, and water skiing. Some incidents are linked to alcohol abuse, which tends to interfere with judgment and promotes risk-taking. Other victims overestimate their stamina. Drownings can also occur at home or in a healthcare environment. Young children can drown if left momentarily in a bathtub or if they have access to a swimming pool. Swimming pools should be fenced and locked, and children should never be left unattended in a bathtub or a pool. Although the potential for drowning in a healthcare institution is statistically remote, it can happen. Therefore, nurses should never leave any helpless or cognitively impaired client, young or old, alone in a tub of water, regardless of its depth. Prevention. Victims of cold water drownings are more likely to be resuscitated because the cold temperatures lower their metabolic rate, thus conserving oxygen. Prevention, however, is far better. Learn to swim, never swim alone, wear an approved flotation device, do not drink alcohol when participating in water-related sports, notify a law enforcement officer if boaters appear unsafe. CPR, cardiopulmonary resuscitation, if begun immediately, may be life-saving for a victim of asphyxiation or drowning. Current CPR certification is generally an employment requirement for nurses. Many hospitals teach new parents how to administer CPR. Electrical shock. The discharge of electricity through the body is a potential hazard wherever there are machines and electrical equipment. The body is susceptible to electrical shock because it is composed of water and electrolytes, both of which are good conductors of electricity. A conductor is a substance that facilitates the flow of electrical current. An insulator is a substance that contains electrical currents so they do not scatter. Electric cords are covered with rubber or some other insulating substance. Macroshock is a harmless distribution of low amperage electricity over a large area of the body. It feels like a slight tingling. Microshock is a low voltage but high amperage distribution of electricity. A person with intact skin usually does not feel microshock because intact skin offers resistance or acts as a barrier between the electrical current and the water and electrolytes within. If the skin is wet or its integrity is impaired, however, the electrical current can be fatal, especially if delivered directly to the heart. Prevention. Use of grounded equipment in the home and healthcare agency reduces the potential for shock. A ground diverts leaking electrical energy to the earth. Grounded equipment can be identified by the presence of a three-pronged plug. In addition to using grounded equipment, other safety measures to prevent electrical shock should include the following. Never use an adapter to bypass a grounded outlet. Make sure all outlets and switches have cover plates. Plug all machines used for client care into outlets within 12 feet of one another or within the same cluster of wall outlets. Unplug machines if they are no longer necessary. Discourage clients from resting electric hair dryers, curling irons, or razors on or near a sink that contains water. Do not use a machine that has a frayed or cracked cord or a plug with exposed wires. Grasp the plug, not the cord, to remove it from an outlet. Do not use extension cords. Report macroshocks to the engineering department. Clean liquid spills as soon as possible. Stand clear of the client in bed during cardiac defibrillation. Poisoning is an injury caused by the ingestion, inhalation, or absorption of a toxic substance. These are more common in homes than in healthcare institutions, although medication errors could be considered a form of poisoning. Preventing medication errors is addressed in the NPSGs for keeping people safe in healthcare agencies. Medication safety is discussed in more depth in Unit 9, Medication Administration. Accidental poisonings usually occur among toddlers and commonly involve substances located in bathrooms or kitchens. Many children treated for accidental poisoning have a repeat episode. Acetaminophen overdose is the #1 cause of acute liver failure in children. Acetaminophen's brand name is Tylenol. Individuals oftentimes are not aware that they have exceeded the daily recommended dose of 3 grams or 3,000 milligrams when fever and pain relief drugs are coupled with over-the-counter cough and cold remedies that also contain acetaminophen. Common substances associated with childhood poisonings: drugs, particularly over-the-counter remedies such as aspirin, acetaminophen, and other pain pills, topical medicines, vitamins, antihistamines, antacids, and antibiotics. Cleaning agents: bleach, toilet bowl or tank discs, detergent pods, and drain cleaners. Paint solvents: turpentine, kerosene, and gasoline. Heavy metals: lead, paint chips. Chemical products: glue, shoe polish, antifreeze, and insecticides. Cosmetics: hair dye, shampoo, and nail polish remover. Plants: mistletoe berries, rhubarb leaves, foxglove, and castor beans. Healthcare facilities have fewer poisonings because they keep medications locked. By law, they must keep chemicals such as liquid antiseptics, which are intended for external use, separate from other drugs. Nevertheless, medication errors persist, in which the wrong medication or dose at an incorrect time is administered or given to the wrong client. Protect older adults with cognitive impairments from accidental ingestion of toxic substances such as medications and cleaning agents by keeping all potentially harmful substances in a secured locked location. The toll-free Poison Help number is provides immediate access to an expert at a poison center with answers to questions about poisons and poisonings. And the poison help number is 1-800-222-1222. Prevention. Children should be educated about the hazards of poison. The American Association of Poison Control Centers promotes awareness for assistance with accidental poisoning with a Poison Help logo. The logo provides a nationwide toll-free number that, when dialed, automatically connects the caller to the closest poison center control. Nurses and pharmacists who are certified specialists in poison information answer emergency calls around the clock. All nurses can teach parents and others how to reduce the risk of poisoning in the home. Adults who have trouble remembering or who cannot administer their own medication safely can use containers pre-filled by a responsible person. Treatment. Initial treatment for a victim of suspected poisoning involves maintaining breathing and cardiac function. After that, rescuers attempt to identify what was ingested, how much, and when. Definitive treatment depends on the substance, the client's condition, and if the substance is still in the stomach. For ingestions of commercial products containing multiple ingredients, the Poison Control Center is consulted. Otherwise, treatment follows the decision tree in Figure 1914, which is on page 424 in Fundamentals in TIMBY. Client and family teaching, preventing childhood poisoning. The nurse teaches the parents or the caregivers the following: install child-resistant latches on cupboard doors, request child-proof caps on all prescription medications, buy chemicals and non-prescription drugs with tamper-proof lids, never transfer a toxic substance to a container usually used for storing food, do not refer to medications as candy, and do not tell children they taste yummy, do not keep drugs in your purse, remind grandparents and babysitters to child-proof their home, remove toxic houseplants from the home, and keep the home well ventilated when using an aerosol or another substance that leaves lingering fumes in the air. Is the following statement true or false? Poisoning is a common hazard found. The answer is false. Poisoning is a common hazard found in the home and healthcare environment. Is the following statement true or false? People with latex allergy may develop a cross-reaction to certain foods. The answer is true. People with latex allergy may develop a cross-reaction to certain fruits and vegetables. Is the following statement true or false? When using latex gloves, a nurse should use oil-based hand creams. The answer is false. When using latex gloves, a nurse should avoid the use of oil-based creams. Falls. Falls, more than any other injury discussed thus far, are the most common accidents experienced by older adults and have the most serious consequences for this age group. More than 1/3 of adults aged 65 years and older fall each year in the U.S. Falls are the most common causes of non-fatal injuries and hospital admissions for trauma. According to statistics from 2013, of 2.5 million non-fatal falls among older adults, 734,000 required hospitalization and nearly 25,500 died, per Centers for Disease Control and Prevention, 2015. Most falls among older adults occur at home. Common injuries include those to the head, wrist, spine, and hip. Up to 40% of nursing home admissions are related to falls. Many who survive a fall suffer years of disability, impaired mobility, and pain. The incidence of falls in general, as well as in hospitals, must be reduced, not only for the associated pain and suffering, but also for financial reasons. In 2013, the direct medical costs of older adults who fell, adjusted for inflation, was $34 billion per CDC in 2015. As an incentive to control costs at the Center for Medicare and Medicaid Services, CMS, has classified falls as one of several hospital-acquired conditions, HAC. A hospital-acquired condition is a complication of hospitalization that is reasonably preventable. As such, CMS will no longer cover the cost of care that was incurred by a fall. Private insurers are following a similar non-payment policy. Osteoporosis, a loss of bone mass, increases the risk of fractures in both older women and men. Osteoporotic fractures may occur with little or no trauma and even without a fall. Older adults who have had a previous fall are more likely to fall again and may experience a fear of falling, which is characterized by gait changes and being overly cautious. Fear of falling could significantly limit mobility, which may actually increase the risk for falls. Practical methods such as assessing risk factors for falls and teaching fall management should be initiated. Placing beds at low heights may diminish risk from falls. Contributing factors. Older adults are more prone to falls for several reasons. Many have age-related changes such as visual impairments and disorders affecting gait, balance, and coordination. Some take medications that lower blood pressure, causing them to feel dizzy when they get up. Others have urinary urgency. And rush to reach the toilet. Other social and environmental factors also contribute to the risk of falling. For example, older adults often wear slippers to accommodate swollen feet. Although slippers are more comfortable, less expensive, and less tiring to put on than shoes, they do not offer much support or traction. Clutter may accumulate around the house if the older adult lacks the energy to clean or does not want to discard old items. For hospitalized older adults, the risk for falls increases. They are in an unfamiliar environment. They must rely on nursing assistance for mobility, and such assistance may not be prompt. Medications and altered health status may cause temporary confusion and poor judgment. Assessment. Determining which clients are at higher risk can prevent some falls. Identifying at-risk clients and preventing falls is also a national service nursing goal. Accredited hospitals and long-term care agencies use assessment tools to determine which clients need fall prevention protocols. Prevention. Different fall prevention approaches are used in the home and in healthcare facilities. Measures for preventing falls are modified based on the client's circumstances. Older adults should keep a list of emergency numbers posted by the phone. Those who live alone may want to become part of a daily phone tree in which someone investigates if an older adult does not call in or answer a call. Personal response services are also available in which the subscriber wears a wireless, waterproof pendant with a button that he or she can use to summon help in an emergency. Activating the button places a call to the manufacturer's emergency response center. Once connected, the user can carry on a two-way hands-free conversation. The center directs calls for assistance to predetermined people such as family neighbors, the physician, or emergency personnel. If the user cannot communicate, the center dispatches emergency personnel to the user's location. The nurse teaches the client or family the following. Keep the environment well lit. Install and use handrails on stairs inside and outside the home. Place a strip of light-colored adhesive tape on the edge of each stair for visibility. Client and family teaching preventing falls. The nurses teaches the clients and the family as follows. Keep the environment well lit. Install and use handrails on stairs inside and outside the home. Place a strip of light-colored adhesive tape on the edge of each stair. Remove scatter rugs. Keep extension cords next to the wall. Do not wax floors. Wear well-fitting shoes that enclose the heel and toe of the foot and have non-skid soles. Keep pathways clutter-free. Wear short robes without cloth belts that may loosen and trip the patient. Use a cane or walker if prescribed. Replace the tip on a cane as it wears down. Stay indoors when the weather is icy or snowy. Sit down when using public transportation, even if it means asking someone for his or her seat. Install and use grab bars in the shower and near the toilet. Place a non-skid mat or decals on the floor of the tub or shower. Use soap on a rope or a suspended container of liquid soap to prevent slipping on a loose soap bar. Use a flashlight or nightlight when it's dark. Make sure that pets are not underfoot. Mop up spills immediately. Use long-handled tongs rather than climbing on a chair to reach high objects. Restraints. In healthcare agencies, fall prevention measures are necessary for identified clients. The use of restraints, however, is closely regulated. Physical restraints are methods that immobilize or reduce the ability of a client to freely move his or her arms, legs, body, or head. Chemical restraints are medications that are not a standard treatment or dosage for the client's condition, but rather are used to manage a client's behavior or freedom of movement. These are generally warranted to manage violent or self-destructive behavior that jeopardizes the immediate physical safety of the client, staff, or others. Physical restraint devices that may be used for client safety include those that protect a client from falling out of bed or permit the client to participate in activities without the risk of physical harm. Remember, chemical restraints are not medications. For example, analgesics, commonly included as part of a client's regimen. Rather, they are medications such as antipsychotic agents given to specifically manage the client's behavior or freedom of movement. Wandering is not a justification for restraining clients. Older adults who are confused or otherwise cognitively impaired without an awareness or appreciation for personal safety may need alternative precautions to prevent wandering. Helpful devices include placing a specially designed net with a stop sign across the exit doorway with Velcro, also using bells over doors to alert caregivers, or disguising an exit door by covering it with a curtain or wallpaper that blends in with the surrounding environment. Several different types of monitors, identification bracelets that include a phone number, and alerting alarm devices are available to reduce the risk for wandering. Several different types of monitors, identification bracelets that include a phone number, and alerting alarm devices are available to reduce the risk for wandering. Special environments may be designed so that the hallways form a circle around the nursing station, allowing the older adult to walk yet remain in view of the nursing staff. Caregivers should be aware that early identification is necessary so that proper precautions can be initiated. Daily documentation of what a person is wearing is helpful should the client wander and need to be identified. The Alzheimer's Association, 1-800-272-3900, sponsors a program called Safe Return, which facilitates the reporting and return of people with cognitive impairments who become lost. Local police departments may provide a service of digital photography of the older adult and coded identification bracelets. The photos and identification codes are stored in the computers maintained by the police department for identification of an adult found wandering. Clients with dementia may also be fitted with a GPS device to facilitate locating a missing person. Although the use of restraints may be intended to prevent falls and other injuries, in many cases their risks outweigh their benefits. Restrained clients become increasingly confused. Suffer chronic constipation, incontinence, and infections such as pneumonia and pressure ulcers, and experience a progressive decline in their ability to perform activities of daily living. Restrained clients are more likely to die during their hospital stay than those who are not restrained. It is unethical and a violation of the Joint Commission standards to use physical or chemical restraints for disciplinary reasons or to compensate for limited personnel. Restraints must be the last intervention used after trying all other measures to solve the problem. Nurses must take measures to protect the restrained client's health, safety, dignity, rights, and well-being. Legislation. After research studies revealed the widespread use of physical restraints in long-term care facilities, Federal legislation, known as the Nursing Home Reform Law, was incorporated in the Omnibus Budget Reconciliation Act, OBRA, in 1987. Compliance with the law has been mandatory since 1990. Accreditation standards. The Joint Commission followed the lead of OBRA's legislation by developing restraint and seclusion standards in 1991. They continue to revise these standards, which differ for non-psychiatric and psychiatric institutions. The most recent revision occurred in 2009. The standards address three areas: agency restraint protocol, medical orders, and client monitoring and documentation of nursing care. Agency restraint protocol. A protocol is a plan or set of steps that you follow when implementing an intervention. During a Joint Commission's inspection, the accreditation team examines an agency's protocol for restraint use that the medical staff has approved. The protocol must identify the criteria that justify the application and discontinuation of restraints. Non-physical interventions, such as reorienting a person to place and circumstance, or timeout, which involves removing the client from the immediate environment to a quiet room, is preferred. In the case of a client attempting to remove an endotracheal tube that facilitates mechanical ventilation, personnel must first attempt less restrictive measures, such as having someone sit with the client. Medical orders. A physician must write a restraint order, or a nurse must obtain one from a physician by telephone within 1 hour after the restraint is initiated. If a physician is unavailable, a registered nurse who has knowledge, training, and experience in the techniques that necessitate the use of restraints may initiate restraint use based on appropriate assessment of the client. If need for a restraint used to protect the physical safety of a nonviolent or non-destructive client is ongoing, the physician must renew the medical order according to the agency's protocol. Monitoring and documentation. The client's chart must contain documented evidence of frequent and regular nursing assessments of the restrained client's vital signs, circulation, skin condition or signs of injury, psychological status and comfort, and readiness for discontinuing restraint. In addition, the nurse must record nursing care concerning toileting, nutrition, hydration, and range of motion while the client is restrained. The documented care must reflect the agency's established protocol. The nurse also must promptly communicate with the client's family regarding the need for restraints and notes the time in the documentation. When the assessment findings indicate that the client has improved, the nurse must legally and ethically remove the restraint. Restraint alternatives. Agencies are being challenged to implement interventions that protect clients from injury while ensuring their freedom, mobility, and dignity. The intent of both the OBRA legislation and the Joint Commission standards is to promote restraint alternatives, protective or adaptive devices that promote client safety and postural support, but that the client can release independently, and eventually restraint-free client care. Restraint alternatives are generally appropriate for clients who tend to need repositioning to maintain their body alignment or improve their independence and functional status. Some examples include seat inserts or gripping materials that prevent sliding, support pillows, seat belts or harnesses with front-releasing Velcro or buckle closures, and commercial or homemade tilt wedges. I'm not sure if the seat belts are approved anymore either, so check with your agency's protocol. If the client is unaware of or cannot release the restraint alternative, it is considered a restraint. Other supplementary measures that may reduce the need for restraints: healthcare providers are encouraged to improve gait training, provide physical exercise, reorient clients, encourage assistive ambulatory devices such as walkers and hall rails, and use electronic seat and bed monitors that sound an alarm when clients get up without assistance. Again, I don't know if those are still allowed. You need to check with your facility. Before considering the use of physical restraints, the nurse observes and documents the client's response to other alternatives. When clients are in a wheelchair, the nurse must position them correctly. The use of restraints. When the use of restraints is justified, nurses and the healthcare providers they supervise must demonstrate continued competency in their safe application. Skill 19.1 explains how to apply restraints and use them appropriately in your Fundamentals book by Tim B. Nursing implications. Nurses must recognize safety hazards and identify clients at the greatest risk for injury. Once they gather and analyze the data, they may identify several nursing diagnoses. Risk for latex allergy response, risk for injury, risk for trauma, impaired walking, acute confusion, chronic confusion, risk for poisoning, impaired home maintenance. And if you look on page 428, there's a nursing care plan 19.1 risk for injury that's all written out. So you can take a look at that in fundamentals. Despite appropriate assessments and plans for preventing injuries, accidents still occur. When they do, the nurse's first concerns are the safety of the client and the potential for allegations of malpractice. Therefore, if an accident occurs, the nurse takes the following actions: checks the client's condition immediately, calls for help if the client is in danger, begins resuscitation measures if necessary, comforts and reassures the client, avoids moving the client until safe to do so, reports the accident and assessment findings to the physician, and completes an incident report as soon as the client is stabilized. This is the end of the slideshow.